Good afternoon. Good afternoon. Okay, so we'll get started now. And I request everybody who's outside if you can come in. We have a very rich session today. So in the interest of time and giving our speakers enough time to share their insights and learnings, we'll get started. My name is Somesh Kumar. I serve as the Senior Director for Jhpiego. Good afternoon, Excellencies, colleagues, partners, and friends. On behalf of Jhpiego, it is my honor to welcome you to this event, co-hosted with our esteemed partner, the Children's Investment Fund Foundation. Today, we gather to celebrate and learn from country leadership for transforming women's health, especially efforts that are driving meaningful and sometimes dramatic reductions in maternal mortality. As a global health organization deeply rooted in country partnerships, we at Jhpiego have long witnessed the power of national leadership, innovation, and commitment in advancing women's health. Today's conversation is not only timely, it is essential. We are privileged to be joined by leaders from India, the African Union, Tanzania, and Ethiopia, whose efforts are driving real and lasting change. We are grateful to our partners at UNITAID, MST for Mothers, and the World Diabetes Foundation for their participation in this important conversation today. Now let me give you a brief overview of our program today. We'll get started by hearing from the Additional Secretary and Mission Director, National Health Mission from India, Ms. Aradhana Patnaik. As we know, India, through bold policy reforms, strategic financing, and scaling of proven interventions, has made unprecedented investments in women's health and maternal survival. Ms. Patnaik will talk about India's journey in this regard. We'll then hear from Ms. Sheila Shawa from the African Union, who will talk about impressive journey of Africa in championing women's health across the continent. Africa's journey is a testament to the power of listening to women, to communities, to evidence, and acting with determination. It will be a privilege to listen more about that journey today. These initial remarks will be followed by two rich panels designed to spotlight country action, strategic partnerships, and global South-to-South exchange and collaboration. Our first panel will be moderated by Dr. Jeffrey Smith, Senior Technical Manager, UNITAID, and will bring together experiences from Ethiopia, Tanzania, and India. Our panelists will share the strategies, insights that have helped them move the needle on maternal survival. The second panel, moderated by Dr. Himang Shah, Director at the Children's Investment Fund Foundation, will shift the lens to partnerships and exchange and collaboration in the Global South. This discussion will feature the work of Dakchin, an organization based out of India, William Mkapa Foundation from Tanzania, along the critical contributions of funders like MST for Mothers and World Diabetes Foundation for enabling a powerful model of South-to-South exchange and collaboration, including the involvement of the private sector and civil society, reinforcing that sustainable progress in women's health is not only possible, but scalable when local innovation is matched with global solidarity. Let me close by thanking all of you, our country leaders, speakers, institutional partners, and funders for your leadership and our shared commitment. May today's discussion fuel not only inspiration, but action. Now, to move the conversation forward, I would like to invite Ms. Aradhana Patnaik, Additional Secretary and Mission Director, National Health Mission India, for the keynote address. Ms. Patnaik is an Indian Administrative Services Officer of 1998 batch. She brings in varied experience of working in sectors of rural development, drinking water and sanitation, education, and other critically important departments for human development. Please join me in welcoming Ms. Patnaik. Ma'am.
Namaste and warm greetings from India. respected colleagues, esteemed dignitaries, ladies and gentlemen, it's indeed a proud privilege for me to be presenting before you India's journey, not only presenting but basically showcasing India's journey in transforming women's health. Today, as I speak, I would just like to, before starting, just throw a few figures so that you will be able to understand the nitty-gritties, the challenges, the plethora of work that is being done in the country. As I speak today, 30,000 sessions of vaccination have already occurred in the country. Nearly 500,000 children have been vaccinated today. 49,000 pregnant women have undergone their ANC checkups, as I'm speaking to you today. India has had a remarkable journey over the past few decades. A few figures again. There has been a reduction of 86% in maternal mortality. And the recent United Nations maternal mortality estimation report has applauded the work of the country, wherein we have shown a drastic decline in the last 3 years from 103 to 80, 23 points decline in just 3 years per 100,000 live births. So these figures speak for themselves. This has been possible due to the commitment at the highest level, the plethora of schemes, programs that have been implemented over the years, and the results are there for you to see. I would like to just highlight a few schemes because there are quite a number of programs that have provided which have resulted in this outcomes that we have achieved. But a few things which I would like to highlight. First is the commitment and dedication of more than 1 million rural women, the community volunteers whom we call ASHA workers. Their dedication, their commitment, and their one-to-one connect with all the pregnant women in the country has given this formidable result that we are seeing today. A few programs which I would like to highlight is one, the Janani Suraksha Yojana, JSY, which was basically envisioned to promote institutional delivery. Earlier, India was facing the challenge of home deliveries due to lack of access to health facilities by the citizens. Today, through the Ayushman Bharat Health and Wellness Centers, which we have renamed as Ayushman Arogya Mandirs, these are health centers closer to the homes of the people, where pregnant women have access to the antenatal checkups, to vaccinations, delivery, post-delivery issues, all being addressed in one go. The Janani Shishu Suraksha Karikram is one program which basically ensures safe delivery, safe motherhood, starting from the first trimester of the pregnant woman, catching them young, ensuring all the antenatal checkups happen regularly, the vaccinations happen regularly, and ensuring institutional delivery free of cost, free drugs, free transportation system, free diagnostics, food, all the requirements of the pregnant woman, blood, all the requirements of the pregnant woman being taken care of under the JSSK. And then post-delivery, the immunization of the child and the postnatal care of the mother is also ensured. Through the Surakshit Matritva Ashwashan, Suman program, we are ensuring assured services to the pregnant women. And through our digital platforms, we are able to track each and every pregnant woman through her entire cycle. If it is a high-risk pregnancy case, we have the PMSMA, Pradhan Mantri Surakshit Matritva Ashwashan program, wherein the high-risk pregnant women have access to specialized services, that is gynecologist taking care of the high-risk pregnancy cases, following up with them at every juncture whenever required, and ensuring safe delivery. So these are few of the programs which I have highlighted. Most of them which I mentioned were at facility level. The other contribution, the other, I think, revolution which the country has made is the community mobilization. As I said in the beginning, we have more than 1 million ASHA workers who are ground, field-level workers working day in, day out with the pregnant women, taking care of the woman, taking her to the health facility, ensuring institutional delivery, ensuring that her nutrition component is taken care of. If she is a high-risk pregnancy case, then ensuring that she reaches to the right higher facility, and post-delivery, taking care of the mother as well as the child, making home visits, and also taking the pregnant woman, and after the delivery, the postnatal care being taken up if required at the facility level. Apart from that, we also have community-level institutional mechanisms. We have the Village Health and Nutrition Day, where antenatal checkups keep happening for the pregnant women, counseling of the pregnant woman for family planning for future, safe motherhood practices being shown to her, basically she being guided by the ASHA workers and the auxiliary nurse midwives. And also the village health sanitation committees, which regularly keep meeting to ensure that the health of the pregnant woman is up to mark, and any assistance she requires is also taken care of. Apart from this, we also have the Jan Arogya Samitis, the Mahila Arogya Samitis, which are at the institutional level, which regularly follow up with the pregnant woman and also ensure that all the services are provided to her in a time-bound manner. Providing free access to drugs, to diagnostics, to all the services which are required has reduced the out-of-pocket expenditure drastically, and this has become the main game changer in ensuring that the mother and the child both are safe. A few additional interventions which are specific to the requirement of the area. We have hard-to-reach areas where access to the nearest facility is a bit difficult. So maternity waiting homes, birth waiting homes also we call them, Matri Grih in Hindi we call, they are provided at the health facilities where women are transported and brought to the health facility in advance, say 15 to 20 days in advance, especially in case of high-risk pregnancies, so that institutional delivery and safe delivery happens. We have a robust digital platform for tracking the pregnant woman, the RCH portal through which the entire pregnancy routine is being tracked. For the pregnant women, we have the UWIN platform, very recently launched by Honorable Prime Minister, which tracks the vaccination schedule of the child after the child is born. And for various other complications, be it NCD, be it other diseases, we have various digital platforms through which the entire journey of the woman is being tracked. Through the Ayushman Bharat Digital Health Mission, we also have electronic health records being created and continuum of care being ensured through tracking of the Abha ID. These are a few interventions. The story is long. Interventions are, if I go state by state, we have new stories to unwind every day. Every day new interventions are happening. I gave you a broad outline of the overall interventions which are happening at the national level. At the state level, at the district level, smaller interventions which pertain to the requirement of that a specific area is also being catered to. And all these concerted efforts have actually resulted in the drastic reduction in maternal mortality rates as well as infant mortality rates in the country. And we are committed to achieving our SDG goal of reaching 70. We have already reached 80 as per the latest reports. So we have 10 more points to reduce. And I'm sure that with the concerted efforts of the healthcare professionals, the development partners, the commitment at the highest level, we would be definitely able to achieve it. Thank you.
Thank you, Madam, for sharing the remarkable achievement that India made on maternal health. And I am really honored to be part of that journey, though in a small way. Now, Dr. Sheila from African Union is supposed to be here, but she is stuck in traffic. So we will go ahead with our panel. So I'll start with panel discussion. And our first panel, as Dr. Somesh mentioned, it will highlight achievement from countries Tanzania, Ethiopia, and India. And we will talk about proven implementation interventions, which are implementation of proven intervention at scale, and innovations that are being tested and making difference. I will now invite Dr. Jeffrey Smith, Senior Technical Manager from UNITAID, to be a moderator for the panel. Now I'll request Dr. Grace, who is serving as a CMO with Government of Tanzania. Dr. Matthew, who works with Government of Ethiopia. Oh, yes.
Wherever you would like. Hi, Grace.
And Kritika Murali from Jhpiego, India. So, Dr. Jeff Smith, sir, over to you.
Great, thank you. Welcome to the panel, and thank you everybody for coming. I think this is a wonderful opportunity for us to talk about innovation and implementation. I think everybody knows that maternal mortality is not a problem that can't be solved. Clearly, the recent data that was presented by WHO shows that maternal mortality is coming down. I think we lament the fact that it's not coming down fast enough, but it is coming down. We are making progress. We're going to hear about progress from these incredible panelists today. But we still, just because it's coming down doesn't mean that it's coming down fast enough. There is an enormous amount of work left to be done for mothers and newborns. There's a lot that has to be achieved. If you look at countries like Central African Republic and Chad, their maternal mortality is still 700, incredibly high, whereas in Australia, the maternal mortality is 2. 300, 400 times difference between countries that have solved this problem and countries that are still working to solve this problem. But the progress that we have heard about in the last few years, in the last 15 years, what has gotten us here has been an increase, just as was presented, an increase in women coming to facilities for antenatal care, for intrapartum care, for postpartum and newborn care. Increasing access to service. What we need to do now is we need to improve the quality of those services. We need to make sure the services provided to women are by the right provider, and even though I'm an obstetrician, I think the right provider is a midwife. The right provider in the right environment, providing the right services with the right health products. At UNITAID, we're dedicated to making sure that women have access to the products they need when and where they need them. So making sure that services are of high quality and that we are engaging with women to ensure that they come to care and that they get good quality care is the focus of this panel. And I think the panelists today are really going to share some of the incredible stories and things that they've done to increase access and to improve quality and overcome some of the challenges. I think every time I look at my phone, I look here in Switzerland, I'm based here in Geneva. Here in Switzerland, we have an app on the phone called Twint. That's a mobile paying app. Every time I look at that, I thank Kenya, because Kenya is the country that started M-Pesa. the whole mobile money revolution that all of us use on our phones. The solutions for better services don't come from Geneva, they don't come from New York, they don't come from Seattle, they come from the countries. So we're going to hear today about some of those interventions, those innovations, and how you all have led change to make services for mothers and newborns better. So I think the bios, let's get that person off of the screen, and let's put the bios up of our esteemed colleagues, because we really want to hear from them and what they're achieving. So I want to ask a question to all of you, a general question. Each of your countries has made notable progress in reducing maternal mortality. We've seen in the latest maternal mortality figures that maternal mortality has come down remarkably in every one of your countries. And you've implemented many, many things. There is not one solution for improving maternal newborn survival. So if I could ask you to just choose two of your favorites, two of your top interventions that help to reduce maternal mortality in your countries, what would they be? Let's start with Dr. Grace Makembe.
Yes, so good afternoon, everyone. Glad to be part of this panel. And yes, I'm here to share, but I'm also here to learn. Yeah, so as you just said, Tanzania is one of those countries that has achieved a remarkable reduction in maternal mortality. Just in 2015-2016, we had maternal mortality of 556 per every 100,000 live births. And in 2022, we had reduced by 80%. That is 104 deaths per 100,000 live births. And as he said, there isn't one intervention that was instituted. But today, I'll just talk about two. I'll just share with you two interventions. One is strong political commitment, and second was a massive investment in primary health care. And how did we arrive to that? It's the data that actually showed us where should we invest our energy. So with a strong leadership or political commitment, I would really want to commend our current president, Her Excellency Dr. Samia Suluhu Hassan, who by then was a vice president. So as a vice president, she was tasked to make sure that, her fellow women will survive through childbirth. And what did she do? One was to make sure that all the leaders in the sub-regional, in the sub-country regions actually had commitment. They were tasked to make sure that they review, together with the technical people, every maternal death that happens. They had to know why it happened, what went wrong, and what should be fixed so that next time we do not see the same problem, that mothers do not die while they bring life. But the other thing, of course, we had an issue with anemia. So she also signed a compact, an MOU with all the subnational political leaders, making sure that every woman, they get access to all the tests to make sure that we know their blood group, we know their blood level, and take all the appropriate measures to make sure that, they have their hemoglobin ready to facilitate them through safe delivery. But the other thing that was done was to increase the budget. Our budget increased, the health budget increased from $760 million in 2018-2019 to a tune of $946 million. And this enabled us to train more staff, but also to employ more staff in the health sector. Because by then, we had a deficit of less than 40%. Okay, so that money also helped us to employ more skilled staff. But the other thing was perinatal review of all maternal deaths and newborn death. That was done, and this was done actually, Tanzania, just like any other countries in the sub-Saharan region, we are constrained when it comes to infrastructure. So we employed technology through WhatsApp groups, through all other means to make sure that every death that happened, actually we participated in reviewing, but also sharing with staff what really happened. And the last thing in that one political commitment aspect is the health sector was permitted to employ about 30,000 new skilled staff. The other intervention that really brought results as I said, was the investment in primary health care. Back in my country, 80% of all the deliveries, they take place in the primary health care. So we thought that's where we should invest. And by then, only less than 50% of our communities had access to a primary health care within 5 kilometers of their radius. So what did we do? Within a span of 5 years, the government invested into more than 1,400 primary health care facilities. And actually, out of those, 596 were equipped to provide comprehensive emergency obstetric care services, just to make sure that any woman who comes with a complication that requires surgery, a cesarean section, an emergency cesarean section, actually would get it immediately. And this also gave us another result, that is by 2023, right now, about 75 to 80% of our communities, they can access primary health care services within 5 kilometers of their radius. So I think those two, I thought they were very important to share.
I love it, Dr.
Thank you.
Grace. Number one, part A, B, C, and D. Part two. I think use of data and a strong understanding and a reanalysis of your health system, and using that reanalysis to increase your budget. That is absolutely critical. Now I want to ask the same question of you, Dr. Tedeke Matthews. In Ethiopia gave us coffee, one of the best innovations in the entire world. But you've given the world many more important lessons about how to reduce maternal and newborn mortality.
Thank you, Jeff, and good afternoon, everyone. It's a pleasure to be part of the panel discussion. As it was said, back in 2000, the maternal mortality in Ethiopia was around 871 per 100,000. In 2020, this was reduced to around 267 per 100,000. So if as you said, we did many interventions, but taking two critical interventions, I will highlight two. One is, as it was mentioned by Grace, we highly invested in one of our flagship initiatives, the Health Extension Program. So this Health Extension Program was launched in 2003. By that time, the current Director General of WHO was the Health Minister. So we have launched the Health Extension Program, which we deployed more than 34,000. Currently, we have 44,000 health extension workers at the community level. The aim is to bring the service to the household, near to the household or community. So the health extension program was launched in 2003, which makes the interventions closer to the community. While we are doing this and designing the health extension program, because it was new and innovative, we are not sending them to the universities, but we have sent those cadres to be trained for 1 year on the basic maternal child health program. So we packaged the service in 4 categories. One is maternal and child health, disease prevention, hygiene and environmental health, and the health education and communication. These are the 4 packages. Under each package, there are different services. For example, on the maternal and child health, we have introduced the antenatal care, the integrated community management for children, immunization, family planning. These were critical to reduce the maternal mortality at the community level. The other major design that we have embedded on the health extension program is the service delivery approach. So these health posts or the health extension workers are within the 5-kilometer radius for the households, but while they are providing the service, they use 3 approaches. One, providing the service at the health post. The second, they use outreach, and they will go house to house to provide those services. So based on the service need at the household level, they will plan accordingly. The other part on the health extension program is, so within one health post, there are 2 health extension workers. But identifying the critical need at the household level, we designed a health development army which aims on creating a cadre of women which can liaise households needs to the health extension workers. So we were working on creating model households so that one model woman at the household will have a 5 network. She will teach on the health education and different risks related to the maternal health program. So this is one of the flagship initiative that we have been implementing for the past 2 decades. Now we are revising or optimizing because there is a changing demand on the community level. So we are also optimizing. I will come to that later on. So the second major critical intervention that we did was expansion of health facilities and skilled manpower at the primary health care. So as a referral layer, we have invested heavily on primary health care at the health center level, which can serve as a referral for health posts to manage those who need diagnostic service at the health center. So currently we have around 5,000 health centers, which have 5 satellite health posts. So under each health center or primary health care unit, there are 5 health posts which can get mentorship from health centers. The other is expansion of primary hospitals. So while availing maternal and child health service, there are some areas that we need to intervene. For example, expansion of OR blocks. The cesarean section is basically given at the hospital level, at general and comprehensive, but we designed to embed or to build OR blocks at the health center level. So currently we have around more than 125 functional OR blocks beyond the hospitals, which we have around 400. So they are basically providing this cesarean section for any complication that happen at the health center and health post level. The other, so the other is skilled manpower deployment. More than 25,000 midwives were deployed at the health center level with 1 to 4,000 population ratio, and the GPs on the primary health care. So these are the 2 critical areas that we have been doing.
That's amazing. And I think what I'm hearing is a lot of a focus on integration and primary health care focus, but also how the health extension workers were providing individualized care, going to the households, understanding the household, and creating an individualized plan for that family. That's incredible. We want to hear more about that. But let's ask the same question. I think India has been leading for Asia and for the world in many ways, innovation in addressing maternal mortality reduction and newborn mortality reduction. Kritika Morali is going to start with a video and then tell us a little bit more about some of the innovations that India has done.
Yeah, thank you so much, Jeff. So basically, I am here to just represent, because we didn't have, Aradhana ma'am did speak of stories, many such stories from the States. So we have a story from the state of Rajasthan. So probably we'll hear from them and then there'll just be a short summary from me. Yeah, so can we please play the video?
Looking to the geographical widespread our state is located at, major part of the state being covered under the desert. The challenges in terms of extending the services to the village level had been one of the stumbling blocks. The added environment that has been created to promote maternal health in terms of early identification of pregnant women, identification of high-risk pregnancies, tracking each and every woman, strengthening our grassroots workers of ANMs and ASHAs so that they can do proper counseling of the women. One of the major causes of maternal deaths was anemia, but the introduction of FCM, counseling for diet, that has actually helped There is a complete support system from the conception to the time, not only when the woman delivers, but the child is almost 1 year old. There are support system in terms of referral services, free diagnostic, free medicines, and also linking it to the home-based postnatal care. There is continuum of support and continuum of monitoring at the level of the government. Also standardizing the practices in terms of developing safe childbirth checklist, streamlining the labor room practices, starting from the home level to the village level to the sub-center level, coming to the block level, district level, and coming to the tertiary care center. And when we look back to year 2010-11, where the state stood with a maternal mortality ratio of 255, today, though the latest figures of 2019-20 SRS peg it to 102, we are hopeful that we aim to keep this momentum live, and in the coming 5 years or so, we aim to bring it less than 75. I look forward to support from all the development partners, from our ministry, from Government of India, and from all the team leaders here. With united effort, we can address this challenge and we can overcome the issue of maternal mortality.
A little bit of trouble with the sound, but we're going to, luckily we have Ms. Murali here to help fill in the gaps for us.
Yeah.
What are some of the major accomplishments and a couple of the highlights for you?
Yeah. So I think one of the things that I will probably highlight is, again, what ma'am had already spoken about earlier was, how did India really make childbirth more safer, right? One of the flagship programs was the Janani Suraksha Yojana, which offered conditional cash transfers to women to ensure that, they come to the institution to deliver. But it was not just that, it didn't stop there. It was also about how to really ensure that this care is also given with quality, with respect. So there were also initiatives like the Dakshata and Lakshya, which looked at the whole quality of care perspective which was there. And the second part, which was also highlighted in the video, is the whole continuum, right? Taking care right closer to where the woman is. Decentralizing that ANC care through this huge network of Ashas and ANM. So one such story from another state of Madhya Pradesh, there was this young girl called Tapasya who was facing continuous abortions, and she was located in a very remote village in one of the largest states of India. And they were not able to understand why this was happening, and that was exactly the time the government of India had also launched the GDM, right? So, looking at not maternal health in a silo, but also integrating it with, say, NCDs as well. And so that's when she was tested for GDM, and then she was immediately referred. So there was a multiple of things functioning in that small story, where there was these point of care devices used, to reach where the woman was to get her tested, then to ensure that she was referred, and the continuous follow-ups through the teleconsultation, which ma'am also highlighted through eSanjeevani. So these were remarkable, and the end result was she had a healthy baby boy, right? So there are many such tapasyas, there are many such stories across India, especially where they're very remote, tough terrains. So how ensuring that whole continuum of care, bringing care really closer to the community, closer to the woman, and that is also through investment in primary health care through the Ayushman Bharat. So I would again say that maternal health not really looked in isolation, also looked at integration with, say, NCDs, even TB, so multiple things into play there. So these are the two things that I would.
I think this is a great reminder of what we were saying earlier, that the first strategy has been to increase access to care, bring more women into care. So we have women here for antenatal care, intrapartum care, postpartum and newborn care. But then we need to look at the 4 Ps of service delivery: the right provider, the right package, using the right products, and in the right physical infrastructure. You have to indulge me, the 4 Ps, including physical infrastructure. But I want to get more specific, Dr. Magembe, I want to come back to you. And I want to ask you, in Tanzania, there's been incredible reduction in maternal mortality from 556 in 2015 to 104 in 2022. And I think one of the things that Tanzania has looked at very carefully is the second delay. not only bringing the women closer to services, but also bringing services closer to women. Can you tell us about the M-Mama program and some of the work that Tanzania has done in order to address the second delay?
Yeah, so M-Mama is, M stands for mobile. So M-Mama is an intervention that was designed to address a critical problem that was there, and this was a referral from the lower facilities to the higher facilities. So we realized that we had a number of women actually who were losing their lives in our hands. They are in a facility at a lower facility level, but you can't really take them to the higher facility level in case they need that service. So that's how M-Mama came about. So this is a technological-based intervention, and it really used the technology because we realized that most of our people actually had mobile phones, okay? And we thought, how can we make use of those mobile phones to make sure that they facilitate the transfer of our women, of our pregnant women and our newborns from facility A to facility B in case they need referral. So in doing so, that's when the M-Mama program actually was designed. So how does it work? The M-Mama, actually, we established a 3-digit number, which is in Tanzania. It's 115, okay? And this 3-digit number, any person can call that number. So if you call that number, it will direct you to a nearby community transport. This community transport could be a bajaji, I'm sure most of you know bajaji, or it could be any other vehicle that is very near to you in your community, okay? So once you call this number, that facility transport, that particular transport will come, and they'll help to transfer this woman from one facility to the next facility when they can really get the services that they require. And when it started back in 2013, we were kind of establishing a concept of proof to see if it works. So we started with only 2 districts, and later on, we rolled it into 6 districts. And again, now in 2022, our president, after proving that it worked, because what came out is that in the 6 districts that we piloted, we managed to reduce maternal mortality by 38% and neonatal mortality by 47%. And as a president, she commanded now the entire government to make sure that this system is rolled out in the entire country. So now it is everywhere in the country. And what really happened after we started now, that's when we started seeing the results, okay? You know, those delays, we were able to cut down the delays by more than 60%. But the beauty of it is that because this program was instituted within the context of their communities, because the drivers actually came from the same communities. And these drivers were men. So there was also an additional benefit. Apart from just transporting women, actually men came to learn and to understand their importance in terms of supporting women and avoiding all these delays. So actually men, they took a front seat. Okay, so every time they will hear that there's a woman who needs a transfer from one facility to the next, actually these men will come, and some of them actually were young people. So we saw actually there was another benefit that, you know, men, apart from just being drivers, but they also came to understand why is it important for them actually to also participate in taking care of these pregnant women, because some of those drivers actually, they had their wives as well who were pregnant. But yeah. But
I think this is one of the few times that we're okay with men being in the driver's seat.
Yes.
That's probably okay. Very few.
And another thing that we learned out of it, initially we had some challenges because the payment was sort of like a cash payment, which had its own problems. So sometimes they had delays because the money is collected and then you have to pay them through government systems, which are a bit bureaucratic. So we said, no, let's continue using technology to make sure that they are paid timely to motivate them. And then we started paying them through their mobile phones, okay? So you transfer a woman, immediately you deliver that woman to facility X, your money comes through your mobile phone.
So Dr. Magembe, you've told us about an incredible application of technology. I think in Ethiopia, you were also looking at the application of technology using the health extension workers. How did that work? What was the focus of that program?
Yeah, thank you. So in terms of leveraging the technology with the support of the partners, currently we are implementing electronic community health information system at the health post level that is used by the health extension workers. That basically serve in having all the demographic information of the household level, whether there is pregnant mother, whether there is a child, so that they can link or send a reminder for each household member on the appointment that they have at the health post level. So they know the number of pregnant mothers within their Kabale, which is the lowest administrative unit. One health post is supposed to serve around 5,000 population. So they know the health profile of all the 5,000 population within their Kabale. So the other application that currently we are piloting or implementing is the Innat application, which is, Innat means in Amharic, it's a mother. So that Innat application is used by clients or pregnant mothers, basically to see the health education, the risk, and other basic information at the health post level. So currently more than 25 million records were registered on the electronic health information system at national level, and more than 7,500 health posts are using this electronic community health information, which CIFF is also investing or supporting on defined areas together with the ministry. With this all, what we learned is the government commitment and leadership should be there. So government is very committed. It's not easy to bring around 4,000 health extension workers at the community near to the household. So these are within the government payroll, and the government is taking the leadership in terms of the other areas. We are using the technology in terms of capacity building. So we are not going to call health extension workers to provide training in a hotel or in some setting. So we are embedding the basic trainings within the electronic community health information system, which health extension workers can learn easily on the areas of the package that we have already defined. So there are training packages that they can, by doing, they have to get this community, they have to get a points for upgrading their education, because we want to incentivize them. If they are taking the training, they have to go for upgrading for diploma level.
So an incentive scheme in some way.
Yeah.
Yep.
So we are embedding using technology for capacity building as well as for improving service quality at the.
I love what you said about using an appointment system. I mean, that's something every one of us would expect, that if we have a visit with our healthcare provider, we have an appointment. But I think too often in many places, women come early in the morning, they line up, they stand there all day in the hot sun. We can use technology to create this appointment system. So I want everyone in the audience to get your questions ready, because after we talk to India, there will be a few minutes for a couple questions from the audience. So Kritika, tell us a little bit more about not only did India focus on institutionalizing in the institutional deliveries and incentivizing it with the conditional cash transfers, but then working on the quality. Again, what we were saying before, let's bring the women in, but then let's improve the quality. What's the story in India about how that is continuing to evolve? Because it's not just one program. Yeah. There's Daksha, there's many different programs that are working on quality.
Yeah. So, like you said, it's not just about saving lives. What is important is how we do it, right? Mm-hmm. How India really does it is with quality, with the respect that is provided to the women. So I'll just share maybe a few examples, which basically, so as a partner, coming as a partner, the government of India sets the vision for us. So they set what needed to be done, and what we do is we work very closely in collaboration, and then look at, what are these innovations that we can roll out and see how that can be further, embedded in the system. So coming back to, the story of the quality antenatal care and the whole continuum of care, right? So looking at a three-pronged strategy, like a 3D approach, I would say. Maybe one is, say, the decentralization. So even when you're decentralizing the care, when you're bringing it closer through those those point of care devices, and you're, bringing it to where the woman is. There's also this approach of the quality part through, there's this innovation which was rolled out in one of the states of Rajasthan, which looked at group antenatal care. So it's basically providing that space for the group of women to come together, talk, share their experiences, ensure that they're heard. So, the delay in seeking care is also kind of reduced through that, as a group they're coming together. So that is something that, we are piloting, and we're rolling out with a few states and sharing those learnings. Similarly, when we talk of digitization and data-driven decision-making. So one thing that we'd like to, there are a lot of these innovations that we've come up with using Bluetooth-enabled devices to go and, for testing the women right where they are. But at the same time, while we roll out these innovations, it is important to ensure that they're not looked at, just that alone is not going to be the approach to kind of help, right? So that's one of the learnings that we've had, that when we are rolling out, especially, digital devices or digital interventions, it isn't really a quick fix. It is something that works complementary, and it cannot really replace quality. So and it's important that we design it with the end user in mind. So these are like a few learnings that we have from.
I think this is really critical. I love what you just said. It's not digital care, it's digital enhancement of the quality of care. Using technology. Each one of you talked about using technology to solve a problem, to enhance the care. But at the center of care is still the interaction between the woman and her care provider. That's always going to be the critical nexus of care. So I'm hopeful that there are a couple questions from the audience. I hope someone will ask about how they're going to assess all of this data that they've collected using AI. How are we going to mine the information to learn even faster? Questions from the audience? Please stand up so we all know who's talking.
Hello, I'm Partho Shah from International Federation of Medical Students Association. So my question is, we have talked about schemes such as Janani Shishu Suraksha Karyakaram and Janani Suraksha Yojana that have played a big role in institutionalizing childbirth. And very recently, we have seen a program that has rolled out in our medical schools that is called Family Adoption Program, which is also seeing a great success in taking holistic care of the family. But in your experience, how can the meaningful involvement of young people, especially medical students and young volunteers, be further enhanced and institutionalized to support the effective implementation of such schemes and long-term sustainability of such government schemes?
Great. How do we involve the next generation, not only of health providers, but also patients? Does someone else have a question? Where's the microphone floating? Okay.
Hi, everybody. I'm Aviwa Funani. I'm the Senior Policy Officer for United for Global Mental Health. I'm actually really grateful for this platform, but I'm quite intrigued that we've not spoken about maternal mental health or perinatal mental health, especially when we speak about primary health care, because we know that there are very high rates of postpartum depression and even throughout the pregnancy period. So I'd like to find out, when we speak about primary health care, how are we actually integrating the mental health care of mothers throughout that process?
Excellent, excellent. Is mental health part of your primary health care vision? Maybe one more quick question, and then we'll have some answers.
Here. Let me stand up. I was wondering how was in Tanzania. You mentioned that the delay went down by 60%, and I was wondering, how did you measure? What was the measurement that was used to say that the delay was overall reduced by that?
How did you measure this delay
and
a 60% reduction? Okay, let's turn to you. You're the experts. You all have done this work. Medical students and the next generation, how do we get them involved?
Yeah, thank you. So let me start with the mental health. So as I have said, the we have designed the 4 packages. The focus was on the maternal, so that was where I focused. So on the disease prevention and control, there are the NCDs, including the mental health, which were integrated at the health extension program, as well as the health center. So what the health extension workers will do is, there is a screening tool that they will use for identifying any mental-related health conditions. As well, they will provide counseling during the delivery and after the delivery. So if there is any issue that should be referred to the health center or at hospital, there are satellite hospitals and health centers that they will consult and refer the client. So it's integrated within the primary health care. Also, we are doing in the primary health care at the health center level, we are establishing a corner for dedicated mental health service, which we call a psychiatric clinic. So there are nurses which are trained on that and provide a service. On the youth involvement, I'll speak on 2 sides. So from the service perspective at the health facility level, the adolescent and youth service is integrated at the primary health care level. And there is a dedicated adolescent and youth service or corner especially at the urban area, which brings the youth association to be part of, because we are not going to bring youth to other service outlets at the urban, so that they can engage and have a dialogue with care providers freely. So that's one area which we have integrated.
Maybe Dr. Magembe can jump in and tell us about how you measured the reduction in the second delay. How did that happen in Tanzania?
So, we normally have what we call the MPTCR reviews that we do throughout the country. And during those reviews, we always look at the causes of death. So like we review each and every death. So from those reviews, actually, we were also able to establish that reduction in the delay, because initially the causes would really tell us most of those deaths, actually, they were because of the delays, okay? So we're also able to establish through that. But again, we have community surveys that are normally conducted, okay, to try and establish, the referral system. And this actually, maybe I didn't say, this transport does not only address the referral delay or the delays of the pregnant women, because now we have taken it also to other conditions that needs to be referred. So those surveys, including the MPDCR that we do, were really able to give us the data, and we were able to see that the delays actually more and more cases that were happening because of the delays were reducing.
And I think I've seen other programs in other countries where they were really using digital information, tracking of cases from response time to transport time. So I think there are a number of examples from countries where we can really study this reduction in the second
Actually, you've just reminded me something. In the same M-Mama program, it's not just an issue of referral. So it also tracks, when did this woman call?
Yep.
When did the transport arrive to pick that woman? And when did they arrive to the next destination where they were supposed to go? Okay, so actually this is also helping us to track.
There's a brilliant program in Kenya that is looking at the same thing, really tracking the response times and the arrival times. Maybe some perspectives on you. I know Jhpiego is doing a lot of really good work with nursing students and nursing education, midwifery education. Our question was about medical education, but all pre-service education. Yeah. How can we tailor that a little bit more to the problems that we're facing here?
Yeah, so I think the government of India has already kind of doing that in collaboration with medical colleges, where they are involving the students during their course of study, where they are engaged to be positioned at these far-flung areas, right? Apart from that, another aspect that worked when we were doing work in primary healthcare also is looking at how medical colleges can play more of a mentoring role as well, right? So how can, and especially mapping it to the areas where there is a shortage and where these medical colleges can come and fill in those gaps and, fill those gaps where those doctors are not there. So that, and it could be a great learning experience as well for the students and as well,
I think one of the things that I was taught in medical school is that your best teacher is your patient.
Sure.
Above and beyond anything that you will read in the book, your best teacher is your patient. So getting students involved early in understanding what happens in communities, in understanding the challenges that women and families face in accessing care, that's going to be the most important thing for helping nursing education, midwifery education, medical education, any education, to have practical understanding of the problems that they're going to be asked to solve. I think today's panel really was an excellent example of moving forward. I'm optimistic. I know there are headwinds that we are facing in global health and in maternal health, but I remain optimistic. The problems that we have already seen have been solved with a variety of different interventions. But the solutions that got us to here are not the same solutions that will get us to there. We need innovation. We need new solutions. We need creative thinking. And that creative thinking happens by being engaged, being at the country level, and solving the problems one-on-one. And here have been 3 incredible examples of that, how that has been done. I think even though I was just wrapping up, we have one final question, I'm told.
Not question, basically there was a question on postpartum depression. So since it was not addressed, so I just thought...
I think there was some discussion about how
I would like
mental
to
health...
add
Great,
to
okay.
it is he spoke of mental health. We have in India a concept of mother's picnic. So the mothers, experienced mothers, they interact with the would-be mothers, those who are going to be mothers, and they discuss among them, they share their experiences. And those women who are undergoing this depression or mental health issues, they talk with each other and then provide that counseling and that support. That has really helped within the community itself, apart from the ASHA workers and the community health officers who provide mental health services at the Ayushman Bharat Health and Wellness Centers. So this I wanted to highlight.
Fantastic. And I would actually, I've heard us talk, heard about group antenatal care. I think that is another approach that has really improved the quality of care. And I think we should look at that. We need to look at the power of women's groups and the power of women's networks to support women on their journey in pregnancy and following pregnancy. So I want to thank the panel. I'd like a big round of applause. You've learned it all here, ladies and gentlemen.
So, thank you, Dr. Jeffrey Smith, for such an enriching panel. And one thing that is not in my script, I kept hearing about 3 delay model, So, majority of my life, I focus on 3rd delay. That is delay in providing appropriate care at the facility. But today I came to learn about, delay in seeking care, how group antenatal care can help us in addressing the delay in seeking care. And the 2nd delay in transportation through M-Mama program. So thank you so much for such an enriching discussion. Now I'll go back to panel B. In panel B, we will hear from institutes and donors partners about their role and vision for integration and dissemination of success for rapid adaptation. So I would like to invite my moderator, Dr. Hemang Shah from Children's Investment Fund Foundation. First panelist, Dr. Monica Kocher, who is serving as a health advisor with Dakshin. Dr. Allen from Benjamin William Mcapa Foundation. Ms. Jacqueline from MSD for Mother, and Ms. Sani Frost from World Diabetes Foundation. Dr. Hemang, over to you.
Thank you so much, Yashpal. Thank you so much for this opportunity to explore this particular topic of country-led development. And when country-led development happens, what is the role of other ecosystem partners that they can play so that the learnings from individual countries can also be shared with other countries? So as we have been hearing in most of the discussion these days, there has been a tectonic shift in terms of overseas development assistance. And when there is shift in overseas development assistance, what is it that individual countries are doing. In the previous panel, we did hear about what are the good practices or best practices or innovations that are happening in individual countries. But then the next step is that how do we reduce the gap from innovation to large-scale implementation? Or how do we reduce the gap from where evidence is being generated to programs being formulated and the programs being rolled out at scale? And that's where there could be role of development partners, where sharing of these success stories, sharing of these innovations, where platforms can be created, platforms can be curated, and not just sharing of success stories, but how do we make sure that there are platforms where these success stories actually get implemented at scale in multiple countries. So thank you so much, panel members, and we have an esteemed group of panelists today who will share, whose core purpose is to make sure that South-South collaboration becomes a reality. So we'll start with Dr. Monica. Dr. Monica works with Dakshin, which is India's South-South collaboration think tank. So Dr. Monica, Dakshin plays a pivotal role in advancing India's leadership in South-South partnerships. How do you envision institutionalizing platforms for sustained cross-country learning in women's health beyond pilot exchanges or symbolic visits? And the reason I say so is that many a times what happens is that there is awareness about innovation or awareness about evidence, but how do we make sure that there is sustained engagement and uptake of this evidence and innovation?
Right, Amang. Thank you so much for this question. Honestly, when cross-country collaborations happen, as you just said, they often begin with a very strong, very great intent through pilot projects, through exchange visits, through symbolic MOUs. But then they often lose their steam without creating a long-term impact. And why this happens? Because usually the sustained capacity or the institutional frameworks are lacking in the public health systems to absorb and to create and to build up on all those shared learnings, And this is even more evident in the case of women health, where the challenges of continuum of care, access, affordability need more than a temporary initiative. So Dakshin, Global South Center of Excellence, it was conceptualized in a to give a systemic response to this reoccurring issue. Dakshin, let me explain what it is. Dakshin translates to South in Hindi. And Dakshin also translates to Development and Knowledge Sharing Initiative by the Government of India. Dakshin emerged after India's G20 presidency and WOGS Summit, Voice of Global South Summit, probably in December 2023, wherein more than 125 countries came together at a platform and raised their request to have a platform, a single platform, wherein the cross collaborations could be, between the countries, could be institutionalized. And that is how Dakshin came into being. So how does Dakshin works? Dakshin is actually a platform where mutual learnings happen, on the best practices of different countries, of the Global South countries. And these learnings are disseminated to the partnering countries through webinars, through joint collaborations, workshops, etc., fellowships, and even technical transfers. So Dakshin is trying to build up on mutual learnings which are happening, as Madam Aradhana just said, happening in every nook and corner of India, and not just India, but also in other Global South countries. So this is a concept of mutual learning from each other. Let me give you a few examples, like Ayushman Bharat Digital Mission, where longitudinal health records are created through unique health IDs. And these longitudinal health records help in providing continuum of care to the women, not only during the pregnancy, but beyond. Similarly, we have UPI systems, unique payment interfaces, which is a digital interface where the digital transfers can happen for conditional cash incentives, and direct benefit transfers can happen to the pregnant woman, which not only provide financial autonomy but also to this woman, but also provide transparency and accountability in the system. So all these good practices in India, named by DPIs, they are open source, easily available to any country which wants to utilize it. They are interoperable, they are adaptable, they are scalable, and can be utilized by any partnering country they can use it as a building block to build upon to strengthen their women health systems. So as you can well understand, Dakshin is working on institutionalizing the cross collaborations, these mutual learnings. Yeah. And it is acting as a bridge between intention and execution, between innovation and sustained use. It transforms symbolic cooperation into systemic collaboration, ensuring that women health outcomes do not come through pilot projects, but come through deep, enduring partnerships of the Global South countries. Thank you.
Sure. Thank you so much. So it's very interesting that you said about, like, it almost seems like a 3-4 phase work, right? One is in terms of what is it that it will take to create institutions which are focused on sharing learnings. Second, what are the kind of platforms that these institutions will create over a period of time? And third is, what is the kind of engagement that will be required for different innovations? Because there would be certain innovations which might be easier to transfer, but there would be certain innovations where more collaboration would be required, more intensive engagement would be required, and it would be an interesting journey how the entire sort of sharing happens over a period of time. So coming to you, Jacqueline, MSD for Mothers has supported transformative programs across low and middle income countries. How do you balance strategic alignment with country-owned priorities? And what are the lessons that have emerged on ensuring long-term local leadership of donor-supported initiatives?
Thank you. Thank you for the question. And good afternoon, everyone. Thank you so much to Jhpiego and CIFF for hosting this conversation. It's really an honor to be a part of this powerhouse panel of female leaders. So just want to celebrate that for a moment. I think the most important thing in response to your question related to advancing strategic priorities while also supporting country leadership is, as a funder, to move in a way where your strategy is not the driving force. As a funder, it has to be part of how you move through the world. It has to be part of how your team is working to drive impact. And so through our Global Maternal Health Initiative, MSD for Mothers, and really through all of the social impact efforts that our company supports, we've learned the importance of, I think, centering 5 key principles as a funder. One is the importance of co-creation with country leadership. We heard this today. We heard it from the panel that preceded us. Countries own the plans. Our role as a funder is to support. It's a supporting role. The second principle is around deep engagement with people with lived experience. And by that, I mean patients. I mean the family or community support system around the patient. And I mean our healthcare providers, really deeply listening to their experience and the local context and what solutions are needed, where the gaps are. The third is around designing for scale and sustainability and potential replication through South-South collaboration from the start. And that can be really challenging at the start of a project, but it's important to be asking those questions urgently at the beginning so that you can design for it. And then the final principle that we think is really important is around spotting opportunities for collaboration where you can bring together unlikely partners. And from our company, from our initiative, we especially look to private sector solutions and local community-led organizations that we might be able to support in partnership with country leadership aligned to ministry priorities. And I'd love to just share a brief example from India. We've talked a bit about India today. We heard from the Honorable Minister. We heard from Ms. Murali about the many schemes that are driving the progress that we're seeing in maternal and newborn health outcomes in India. And one additional ingredient that's been part of helping to drive these changes that I'd like to spotlight has been a companion effort focused on quality, specifically focused on uplifting and establishing quality standards in all of the private facilities across India, where more than 40% of women are accessing their healthcare services related to maternal and newborn healthcare. And so we've helped support this through a long-standing multi-year partnership with Jhpiego, with the Indian Society of Obstetrics and Gynecology, with FOGSI, and others, in collaboration with national and state leaders. And now we're so proud to share that thousands of hospitals, small local hospitals across the country, have now been certified related to the level of quality service that is provided around maternal and newborn health. Thousands of providers have received this quality certification. And so as we're continuing to advance in helping more women access health facilities, we have guarantees related to the quality of service that they'll receive. Those services will be safe, they will be high quality, they will be respectful. And what's really exciting is that we are starting to spot some potential opportunities around South-South collaboration looking at this model from India. And there's been great interest in the regional OB-GYN society in potentially replicating the approach in other countries that are interested. So, thank you.
Great. Thank you so much. So after 4 Ps that Jeff told us, we have 5 principles from Jacqueline to remember. But you make an important point in terms of the engagement with the private sector, and there also there is this scope of South-South collaboration, because FOGSI in India, which is Federation of Obstetricians and Gynecologists in India, has a great sort of opportunity to engage with FIGO. Yeah. And what is it that FOGSI has learned in India? So there are multiple channels of government to government, South-South collaboration, private sector to private sector collaboration, and all the ecosystem partners who can identify those threads of interacting across geographies. Exactly. Another important point I also wanted to highlight is that normally it seems that quality in private sector is a given. Mm-hmm. Which is not the case that we have learned from Manyata work and multiple other initiatives, that even in private sectors, there would be need of regulation, but there would also be need of hand-holding support, so that overall quality is not a given in private sector, and there will be effort that will be required to improve quality even in the private sector.
We can improve quality everywhere.
Right. Great. So to you, Ellen, the Benjamin Mkapa Foundation has been instrumental in scaling workforce and system solutions in Tanzania. How can South-South collaboration enable peer-driven health workforce strategies that address both equity and sustainability in maternal health?
Thank you very much for the very good question, and I'm also very thankful to be part of this panel, the very powerful women health leaders. Going back to Tanzania, I would like to allude first to the former speaker who came from the government as well, whereby we must appreciate our country has a very strong health system, as a resilient and sustainable one. And we appreciate that the investment which has been going on is not only on health infrastructure and strengthening the primary health care, but also reinforcing the health workforce initiatives at the country level. However, we know that there's always been a challenge, which is a common challenge in most of the African countries, in terms of having a limited health workforce in the health facilities based on the requirements. And our country is no different. We still, though the gap has been reducing, we still have a gap of almost 40% of what is required. So we're working with about 60% of the health workforce. So our organization was adopted 20 years ago by the former president of Tanzania with the main mission of complementing the government efforts in terms of improving health outcomes through human resource for health investments. And we've been doing this through different partners, but very closely operating with the government. And I must say we've focused mostly in the public health facilities, because still our country is being served by the public health facilities, but of course with the private health facilities as well. The population is about 65 million people and still having a very youthful population. So when we're inventing our initiatives on health workforce, we looked at, we had like dual prongs approach, not only innovating interventions at the grassroots level, I mean at the ground level, but also very much engaged at the policy table discussion and advocacy. And we felt that was very important to complement each other. And how we've been designing most of our program is very closely with the government, from conceptualization, the co-creation, as mentioned by my other speaker, that the co-creation part must go hand in hand, not only ourselves, but with the government and other players. And here we're looking at the beneficiaries, the local government system, which is very decentralized in our case, the development partners themselves, but even themselves, the health workers are being involved and being represented by their professional councils and associations. And through our initiatives, which we've been undertaking in the country, we are seen as one of the trusted partner by the government and partners, a technical hub which comes up with solutions that are aligned to the government systems and structures and easily to replicate and scale them up. And that's how we've become very successful. So I just like to highlight like 4 areas that we feel will be of benefit with the South-to-South collaboration. When we started all our initiatives, the target was to see how we improve HIV/AIDS healthcare delivery. But with time, we expanded beyond to maternal health care as well. And through that way, we added more quantities of health workforce through hiring innovatively and in a fast-tracking model health workers. These are doctors, nurses, lab, etc. And we've so far been able to hire more than 7,000 health workers in the last 2 decades. But we have a special agreement with the government that we will hire in a fast-tracking model. They'll be supervised by the government district facilities. With time, the government will be absorbing them and mainstreaming them in the permanent and pensionable employment. And this has been very successful. More than 50% have been streamlined within the government facilities. So that was one area. But also we've been looking at how to improve quality of health workers in terms of building their capacity and competencies through e-learning programs, which were instituted within the government facilities, but also at the same time doing coaching and mentoring with those within the district systems. So I think this is something that can be adopted. And I've always been saying we normally have platforms for sharing north to south. We see a lot of attachments north to south. Why don't we also consider the south to south attachments? And I think there's a lot to share from different south regions, such that we can have more attachments within the facilities and vice versa. But also we instituted a platform, a regional platform of having, a national platform of Human Resource for Health Conference, which is carried out once in every 2 years. But we just learn within what is in the country. We feel this is a time to expand that kind of platform, to involve also other South regions to be part and parcel of that platform of Human Resource for Health. Yeah.
Great. No, thank you so much. Like as most of us know, human resource for health is one of the basic pillars for a health system which can deliver better services to all the patients and clients. And here is an example of, again, working or co-creating with the government or working under the vision of the overall government, but then having agility to create those solutions which will deliver results, but also generate insights which will be helpful in geographies beyond the geography that you are currently working in. So thank you so much for sharing those examples. So coming to you, Sanep, the World Diabetes Foundation has long emphasized integrated approaches to tackling non-communicable diseases. How can investments in diabetes care be leveraged to strengthen broader health system for women, especially in the low resource setting?
Thank you so much, and thank you for inviting me to be here today. So the World Diabetes Foundation, we've existed for 23 years supporting diabetes prevention and care in low and middle income countries. If we go back 20 years, diabetes, hypertension, non-communicable diseases in general were not recognized as something, a challenge, neither by development partners, and in many countries they may have seen the emerging burden, they've seen it happening, but at the same time they had serious competing demands that they needed to prioritize as well. So it was, you could say, the new kid on the block, and at the same time also the under-resourced kid on the block, and it remains so largely today. But as that new kid on the block, we were sort of forced to look at what are the different entry points. We didn't want to fall into the trap of siloed approach to just looking at non-communicable diseases, in our case predominantly diabetes and hypertension, but what were the different entry points with TB, with HIV, with maternal health. And of course, by nature, women get non-communicable diseases just like men, so of course there's an obvious entry point. But at the maternal health side, for sure, in terms of gestational diabetes, hyperglycemia in pregnancy in general, hypertension, these were really issues that we could see as challenges. And we recognized it. We found it, I should say, in the early days, a little bit hard to knock on the door of the maternal health community. It seemed that that these issues were not necessarily factored as serious, important challenges. There were other more important issues to deal with instead of gestational diabetes and hypertension. But we saw it as a really ideal entry point. I think many of us see maternal health, antenatal care, child immunization programs as entry points of getting in with additional information. So for us, that was really a window for action. Then the integration, we heard in the previous panel, primary health care integration, people-centered care. These are really the core of what we do at the World Diabetes Foundation, both from a resource efficiency point of view. Many resource or health systems are largely constrained in terms of financing, infrastructure, healthcare providers or staff in the system. But most importantly, actually, from the people-centered point of view, from that perspective, we need to break down that siloed approach. And I just want to share one. Last year at the World Health Assembly, the World Diabetes Foundation co-hosted an event with FIND on TB and diabetes integration. There was a very, very powerful patient advocate present from Zambia. And she stood up and she said, you know, I'm a cancer survivor, I'm a TB survivor, I'm HIV positive, and I have diabetes. She left out whether she had any pregnancies as well during her life course, but just to say that we cannot treat people in these different buckets. We need to look at people as a whole human being. So when you come into the health system and you have, whether you have a pre-existing diabetes and hypertension or you develop it during the pregnancy, that needs to be addressed. If I have one more minute, then because my last point is actually then what we have learned over those 20 years. So looking beyond just, you could say this just, and let me make sure that I put that in quotations, but the safe delivery, and so that the mother and the offspring comes out safely on the other side of the pregnancy. Today we know how gestational diabetes really exposes the mother to early onset of type 2 diabetes and the offspring to early onset of type 2 diabetes, even within adolescence. And when you're looking at health systems in many countries that World Diabetes Foundation supports, they're just not geared to screening and diagnosing and catching that at an early stage, which means that you will find a young person who may be at the age of, I don't know, let's say 20, develops type 2 diabetes, or a mother who develops type 2 diabetes, but because of the symptoms being subtle, and you have a long distance perhaps, or a difficult distance, or you don't have the funding to go to a health facility, you don't go and get tested until something serious kicks in, which means that people get diagnosed when they have kidney failure, when they are turning blind, or all the serious, very preventable complications from diabetes. So for that reason, really the window of opportunity to have a safe delivery, a safe baby being born, but at the same time preventing that fueling of the future generations of diabetes and hypertension. That is really our motivation.
Right. Well, thank you so much. So I think we have seen in past when some of the innovations in reproductive maternal child health, neonatal health has happened in a certain country, and then that evidence, again, evidence to program to policy has taken around, say, 16, 17, 20 years to reach at health post or primary health center. But we could try and avoid that particular situation in non-communicable disease, because now there is increasing sort of awareness, realization across countries where non-communicable disease have also become front and center of the public health response, of the response across different stakeholders. And since most of the countries have this reproductive maternal health system as well-established system, how we can leverage those existing platforms, existing systems to also think about what are the additional services can be layered, where we think from the client perspective, patient's perspective, then from provider's perspective, and then systems perspective, rather than going other way around. So thank you so much for your inputs. Well, I'll just request all the panelists to reduce their interventions to 3 minutes each for the next round of questions. So again, coming to you, Dr. Monica, can you share Dakshin's vision for translation of a successful model of learnings from India to another countries or vice versa?
Sure. As I just mentioned, Dakshin is a think tank, and we work very closely with Ministry of External Affairs. In the past 18 months since our conception, we have already formalized our relationship with nearly 150 think tanks across 85 countries of the Global South. Nearly 12 webinars have already happened, including in health sector, including maternal health. We are also in formalizing our relationships with stakeholders from the public and private health sector. Everybody is welcome to join the platform, especially from the Global South countries. And we are not averse to the Global North. Global North can come as well. So it's a learning platform. Everybody can come in. We envision to have in-person conference very soon, by the end of this year, actually. Wherein all the partnering Global South think tanks will come together and have multiple discussions how they can take this vision forward. So we have done, in these past 18 months, I think we have done a fairly good job for bringing all these global partners together.
Right.
Thank you.
Great. No, that's, again, this is also a learning curve in terms of sharing is important, but how to share is also something that Dakshin and other agencies who are working towards South-South collaboration would also learn over a period of time, that what is the way in which this sharing between Global South can happen eventually.
Absolutely, absolutely.
Coming to you, Jacqueline, what have been most effective ways you have seen the private sector walk the talk on equity as well as country ownership?
Thanks for the question. It's such a good question. And I won't leave you with a long list, but I just would like to highlight two things. The piece related to health equity, I think you have to start in the design phase from a place of what are your local data telling you related to what are the health equity challenges that need solving. And it's really important when you're thinking about examining and supporting analysis and design around that local data set to leverage data that already exists, support additional data collection to fill in big gaps if they exist, but leverage what's already there. And to me, this is the most important. When you're looking at the data and you're thinking about where the biggest challenges may exist or which pieces or segments of the population may be the most underserved or hardest to reach, know that there are strengths and assets in those communities that need to be part of your design. And that's critical to driving health equity. And then finally, as a private sector funder, to be able to support country leadership, in addition to things we've already talked about around amplification and setting our strategy aside and really deep listening, I think it's also very important to create platforms like Dr. Monica is speaking about in order to facilitate the collaboration across countries. And those can be big global regional platforms that are created, but they can also be smaller scale project-based platforms like structuring a community of practice. We have one in an effort that we're supporting called Strengthening Systems for Safer Childbirth, where we bring together regularly leaders from Nigeria, Kenya, Sierra Leone, and India to be in conversation together about solutions that they're advancing, challenges that they're experiencing, and then helping to support that cross-country learning and collaboration. So that's all from me. Thank you.
Great. No, thank you so much. I think use of data has repeatedly come in different form with all the precautions that are needed in terms of use of data. But till the time we look at data in all the granularity that is possible, that's when some of the insights will come in. That's when we will know who are those communities who are most vulnerable and where there is additional need for support that is required. Ellen, coming to you, in your experience, what mechanisms ensure that community health innovations are scaled equitably and sustainably?
Okay. My experience has been that first you need to have right policies in place to enhance the community-based programs. And for our case in Tanzania, for the last 65 years of independence, all of our planning is enshrined within community engagement from the word go. And we have a very strong decentralized health systems, so it becomes even easier. And I'll just give an example of when we were trying to revive the community health workers program in the country, whereby we,
Even better.
Even better?
Yes.
Yeah.
Okay.
Yeah.
So when we were trying to revive the community health workers program within our country with the target of hiring 137 community health workers, 137,000 community health workers within 3 years. The government started with a pilot by defining specific geographical area. Okay. And we were leading, technically leading together with the government, the pilot of that community health workers program to make sure that it's more sustainable, it's well integrated and very well coordinated from the central to the local government authority level. And it's through that way, by engaging the local government, there was more stronger ownership, but also engaging the CSOs, the civil society organization. It also enhanced reaching out the community easily and to be part and parcel of the community health workers program. So engagement of the communities themselves is important. Engagement of the CSOs, it's important. But at the same time, we must appreciate that we need to see best way to package it and become more scalable, easily scalable. Right. And this was the case for Tanzania, and now we're seeing a plan to roll out the community health workers program countrywide. Thank you.
Sure. Thank you so much. I just have received a note from the team here. But Senek, coming to you very quickly in 2 minutes, what are some successful models where diabetes programs have been embedded into maternal or adolescent health services?
Thank you so much. I'll be quick. So I would say what we have learned, we've supported this in many countries. We work with Jhpiego in some states in India. We have worked with KUAM in Sierra Leone. We work in Colombia, many places on this. Basically to demonstrate, make the demonstration, working towards that governments then take on the efforts financing it going forward. I would say what we have learned the hard way is that don't go through the NCD departments to work on gestational diabetes. It's definitely the maternal health departments that you need. And as I said in my earlier statement, opening that door can sometimes be a bit difficult because it's not the first top priority when it comes to maternal health, even though I would argue that gestational diabetes can be the cause of hemorrhage, and it's definitely part of the indirect causes of maternal mortality. The other one, I would say, is build on and embed what you do in existing guidelines. Don't try to come with new things and say, now from base, we're going to go all the way up here. Actually, see if you can put, there's an ANC protocol where you can include diabetes and hypertension. In nutrition guidelines, for instance, now I talked earlier about the future generations. In addition to focusing on iron and iron deficiency, focus on healthy diets, because there's really that window of opportunity. Just want to end with just to say how far we are from also getting there. I was in a country in southern Africa last year visiting a district level hospital, so not a small hospital and quite a busy hospital. And at the end of the visit, the hospital management pulled together but not only the NCD department but also the maternal health, child health, HIV, TB teams to have a conversation with us. And I was curious, so I asked, even though our support was not for this, but I asked the maternal health team, how much gestational diabetes do you see? And they looked at each other, and there were 4 or 5 people, and one of them had been there for quite a few years, and they sort of said, I recall one case about 10 years ago. Now, just to put in perspective, 14% is the global average prevalence of gestational diabetes. So having seen one case 10 years ago, we're far, and that doesn't mean that you don't have the protocols and you don't have the guidelines. They're there. But it's just not necessarily being either prioritized or resources are just too few to actually address it at the facility level. So there's a long way to go.
Sure. Thank you so much. If time permits, we can have just one round of, we'll have 3 questions and we'll take all the question at one go and then we'll request the panelists to go ahead. Yeah. Sorry? Okay. Sorry. If time permits, we can come back after the another keynote session. But thank you so much, all the panelists. And it was a privilege to host all the women leaders and learn from all of you. Thank you so much.
Thank you.
Thank you.
Thank you, Jackie. Thank you. Thanks. All right. Another round of applause for this panel. So we are now joined by Dr. Sheila Shava from African Union. She could join a bit late because she was detained at a ministerial delegation conversation. So, but it's very important to hear from you, Dr. Shava, from African Union perspective on the transforming women's health journey that Africa has taken as a continent. So we are really privileged to have you here, and please join me on stage here.
Good afternoon, and first of all, let me apologize for being late. We were at another event and we were speaking last, and the event overran. So I was just rushing here, but we should have been here earlier. So my sincere apologies for that. And because of that, you know, when you're late, your brain is all over the place. So I will not go into the whole speech, but I just wanted to highlight some of the work that we're doing at the AU in terms of women's health, in terms of maternal child health, so that we can just see how we can collaborate, how we can support each other in terms of working in our member states. So I think some of the key initiatives that we are embarking on is the KAMA campaign. It's the Accelerated Reduction of Maternal Mortality in Africa. And so this campaign was launched in 2009, and I think we've seen that there's been a decline in maternal mortality because countries have really taken this on. So in 2021, we realized that we're focusing on the maternal and child health, but we had left out the component of the adolescent, and also we're focusing on maternal and neonatal, but we had left out adolescent and child health. And so we relaunched the campaign, and it's now called KAMA Plus campaign. And we work with the regional economic communities to, launch this campaign in our countries. I have just forgotten the number of countries that have launched, but quite a number of countries have launched it on the continent. Now, the KAMA also focuses on the theme that no woman should die whilst giving birth, and that, there's need for accountability when we're monitoring the campaign itself. And so we have developed a roadmap that does the accountability of the KAMA campaign to ensure that we have strengthened health systems and we have enhanced collaboration. We also have the safe birth bundle care model, and I think this has been talked about in Tanzania. So we've been working with the team there and other partners to really support the country to do that under the KAMA campaign as well. I forgot to mention our key framework on the continent, and that's, my brain is all over the place, but I think we have the Agenda 2063, and all of us have heard about the Agenda 2063. But if you go to Aspiration 6 of the Agenda 2063, all of that content looks at the women's health. We also have a big chunk of it that focuses on gender. So if you want to know more in terms of what other aspects we're doing outside maternal health in Africa, I think you can go to that document. We have the Africa Health Strategy and the Africa Regional Nutrition Strategy. So I'm highlighting these continental documents because they are policy. So in terms of policy, I think I always tell people we have all the decisions from the heads of state, which show that there's a political commitment. We have the continental policies that guide not only member states, but our partners in what to do at country level. So when we are speaking, we know that that is covered. But I think the challenge we have is how do we convert this policy now into actions? How do we implement? And that has been a challenge. And this is why we are calling on partners to support the countries at national level. We also have to move that political will into commitment. And to move that, it means we have to go into the aspects of financing. How do we, at member state level, finance some of these programs? Yes, we are very grateful for our partners because of the work that they are doing, and we know that they are doing a lot. But I think also health is a public good. It is the responsibility of the government to have ownership of the programs, and then we get the partners to come in and support where the government is failing. So I just wanted to highlight that. But we also, note that we have challenges at continental level, and these are yet to be addressed. We know that we have insufficient workforce, although the picture is now changing, because over the years we're seeing that we don't have enough clinical staff to support our initiatives. When we put all these, when we try to implement, it is difficult because most of our populations are in rural areas. And to support this, the heads of state in 2017 came up with the Community Health Workers Initiative, where we were told to start by training 2 million CHWs, and these will actually support the work of the clinicians in rural areas. And so some countries have trained these CHWs. Some, it's actually a well-organized training. Others, we still have the verticalization, where we have some that are just handling child health, and some just handling TB, and some, like you've said, just handling diabetes. But this is the same patient. How do we just ensure that there is harmonization? So in this the CHW initiative, we have trained with Africa CDC and partners roughly about 1 million. But again, we came back to the realization that we did not have a policy for CHWs. And so even though we are doing this, what is guiding the continent? So we're in the process of developing a policy. And then the last framework that we are working on is the strategic framework on prevention and management of anemia on the continent. And I think we know that there's, there was no data, but in the past 2 years, we've done some research, some surveys that shows that anemia is a big problem. And there's so many causes, infections, and some of them is just heavy menses, and so many, pregnancy. So we're saying, how do we manage this? Because then when we're talking about women's health, we want to manage it from a holistic point of view and not from an individualistic point of view. So the survey showed that we need to, the problem is large, and I think our main aspiration is by 2030, we should reduce anemia by 50%. So if we're targeting 50% in 5 years, I don't have the data, but this information is on our website. It means that the problem is quite magnificent, and the heads of significant, and the heads of state adopted this framework in February. Now, when it comes to strengthening collaboration and partnership, I think the main one is what we are going through now. We have seen the cutting of the aid. So how can our partners support countries in really looking within for support? Because yes, we have depended on external support for a long time, but now how do we move? Because this has been dwindling. How do we move to ensure that the support is coming from within the countries? How do we utilize the public-private partnerships? How do we look at innovative financing for health when we're looking at women's health? How do we ensure that our governments, we know the 15% Abuja Declaration, even for those countries that have attended, is not sufficient. And I want to say this because, we always hear that only 2 countries, only 3 countries have attended the Abuja Declaration. I think from the data we have, a lot of countries have attended Abuja Declaration from 2001. The problem we have is the maintenance. So, the sustainability. You have a country that achieves the Abuja Declaration for this year and next year, and then next year, after 2 years, it goes down to 8%, it goes down to 12%. So we're saying, how do we sustain this? But we've also realized that when countries come on board and when they want to really analyze the Abuja, when they start talking about salaries, when they start talking about infrastructure, hospitals, clinics, it's more than the 15%. And so we are capping it to the operationalization of the health system. So we know that the 15% will not be enough. So what are other innovative mechanisms that we can use to support our countries? And so this is why the South-to-South learning is very important, where we're talking about learning from Asia, South America, and Africa. What has worked in other places, and how can we not get the best practices per se, but the adaptive learning, where we get a good thing and then we adapt it, to our context, instead of just copying and thinking that it will work in our context. So I think that is critical for us. And I think when we had the conversation with CIFF and Jhpiego, it's a new relationship, but I think we agreed that we're going to explore this further and see how we can actually have other initiatives that follow up apart from this side event. So I think with that, we also noted that we need to have a strong monitoring and evaluation system. And because that will be like a learning curve for us, where we have not done well with the Karma campaign, where we have not done well in other initiatives, how can we learn from our other colleagues and ensure that we improve? How do we actually maximize on research, implementation research when we are implementing these policies at country level? So with that, I think there's a lot to say, and I think most of our documents are available, and now there's AI, so you just Google there, it will give you some of the work that we're doing. So please feel free to read about us and get in touch, because we have a strong team. We're working with the REX. I think some of you might know the REX. There's SADC, there's EAC, there's WAHO. So we're collaborating with that on Karma campaign. So and we're happy to see how we can just collaborate with all of you in this room to just move this agenda along on maternal, on women's health on the continent. Thank you so much.
Thank you, Dr. Shah. What foresight and strategic visioning that you have done, and thank you for sharing that with us. Now I want to invite my President and CEO, Dr. Leslie Mancuso, to give the closing remarks. Dr. Mancuso.
And you're still here. Thank you, thank you. Well, on behalf of Jhpiego, thank you to everyone who made this day possible. I want to acknowledge key partners, our co-host, the Children's Investment Fund Foundation. Thank you for your visionary support. I really thank you so much. And to the Ministries of Health of India, Ethiopia, Tanzania for generously sharing their experiences. I want to thank all the speakers and panelists from Dakshin to Benjamin Mkapa Foundation, Unitaid, MSD for Mothers, African Union, and so many others. Your insights have brought today's conversation to life. And to our audience, thank you for your staying so long and your commitment to advancing women's health. As we close this inspiring gathering, I'm filled with both hope for the future and deep gratitude for what we've shared today, a reminder that what's possible when we come together with purpose. What we've heard is a compelling testament to the power of leadership rooted in vision, innovation, and deep commitment to their people. The kind of progress we've seen, once thought out of reach, is now real and measurable. From India's transformative maternal health reforms that have halved maternal death rates in just over a decade, to Ethiopia's community-centered health system, saving countless lives, to Tanzania's groundbreaking work in emergency obstetric care that has reduced maternal mortality. These are stories not of promise alone, but of impact delivered. They reaffirm something we at Jhpiego have long believed. The most effective solutions are already being built within communities most affected. Countries across Africa, Asia, and beyond are not waiting, they are leading, sharing what works, adapting innovations, and supporting one another in a dynamic exchange of knowledge and actions. This is the kind of leadership the world needs now, data-informed, equity-centered, and shaped by lived experience. Every country is forging its own path, crafting context-driven solutions guided by vision and grounded in community partnership. Together, we are committed to making progress towards our sustainability development goals. And let me say this clearly. At a time when traditional sources of global health financing are under pressure, when some long-standing partners are stepping back, country-led, community-powered action becomes even more critical. It reminds us that true resilience comes from within. It rises from the communities and is built on local knowledge, leadership, and trust. Another powerful thread running through these stories is the strength of regional collaboration. Every success we have celebrated today was made possible by not only global partnerships, but countries actively learning from one another. When a country shares its knowledge with another, we accelerate learning and amplify our collective impact. Today's event itself is a testament to that spirit. From Dakshin's cross-regional platform connecting Asia and Africa, we are seeing a new model of solidarity take shape, led by countries that know these challenges firsthand. We are witnessing a shift. Low and middle-income countries are leading the way, designing and delivering solutions not just for themselves, but for others facing similar challenges. This kind of peer-to-peer leadership is how we will meet our SDG goals, together with ownership and shared purpose. Now is the time to build on these lessons. I issue a call to action for all of us, policymakers, funders, health professionals, advocates, and communities alike. If we invest strategically and we partner genuinely, and we share openly, we can replicate these successes far beyond the countries spotlighted today. We can build a future where every woman, no matter her location, has access to respectful, timely, high-quality care to give birth safely and raise a healthy family. As the President and CEO of Jhpiego, I reaffirm our commitment to health equity and to the dignity and rights of women and families around the world. Equity means that no matter where a woman lives, whether it's a rural village or an urban neighborhood or a community affected by crisis, she deserves the same opportunity for a safe birth and a healthy life. It means we focus on those who too often are left behind and work tirelessly until health care is not a privilege but a fundamental right for every woman, every child, everywhere. Jhpiego will stand alongside national leaders, midwives, community health workers, nurses, physicians, and the like, and local partners. We will continue to innovate, to share what works, and to champion extraordinary leadership we have seen today. In closing, I leave you with this. The stories we have heard are not only inspiring, they are instructive. They show us what is possible when people closest to the problem are empowered to lead the way. Let today be more than a celebration. Let it be a springboard for deeper action. Let it renew our shared commitment to bold investment, collaborative learning, and long-term change. Together, we can write the next chapter of global health, authored by the countries and communities who have always been at the heart of this work. Thank you. And thank you for coming. Thank you for coming.